Welcome. Hello again. For those of you who have just joined, my name is Jennifer, and I'm going to be your moderator for today's webinar. We are excited to present to you today the 2021 E&M Coding Changes webinar. Before we get started, there are a few housekeeping items to go over. Questions that you have for us are addressed via chat message using the Q&A button at the bottom of the screen. Please submit your questions throughout the presentation and they will be addressed. We will answer as many questions as we can during the webinar, and we may request contact information from you in order to discuss your questions. Questions we have for you are addressed using polls. A poll will be conducted before the presentation and after. We encourage that you participate so that we can focus on the areas of interest. Before introducing you to Neha Bhatnagar, I'm going to go ahead and launch our first set of polls. Before introducing, now I will go ahead and introduce to you the presenter of today's webinar. Neha is a medical coding healthcare professional with more than 15 years of experience in the field of medical coding and revenue cycle management. Neha is a certified professional coder and a certified outpatient coder. At Health Prime, Neha is the medical coding manager. She educates physicians on annual financial impact due to incorrect coding, in addition to managing and supporting all aspects of the medical coding operations here at Health Prime. Without further ado, I'm going to turn it over to Neha for the presentation.
Good afternoon, everyone. This is Neha. All right, so I will be providing an overview for what's changing for E&M codes for 2021. All of you can see my screen now?
Yes, ma'am. Thank you very much.
All right. So effective January 1, 2021, there are some major revisions for office and outpatient service CPT codes. That is for CPT 99201 and 99215 only. So none of the other codes will be changing. Only we'll be seeing changes for CPT 99201 and 99215. So before 2021, we used to code on basis of documentation of the below 3 key components. That is patient history, physical examination, and medical decision making. So starting from 2021, we are going to see major changes for history and or physical examination. So from 2021, the extent of history and physical examination is not an element in selection of office and other outpatient service codes. So if we are going to code for a level 4 or a level 5 visit, we do not require documentation of detailed or comprehensive history or physical examination. So the nature and the extent of history and physical examination is determined by the treating physician or other qualified healthcare professional reporting the service. So unlike year 2020, now the physician can make a decision of the extent of physical examination and history needs to be performed on the patient. So if the patient is coming in for an ankle sprain, it's no more required to do a comprehensive history or a comprehensive physical examination on the patient. Physicians can only do a problem pertinent history and a problem pertinent physical examination for the patient. Office or other outpatient services includes a medically appropriate history and or physical examination when performed. So let's look into the new patient E&M codes. In 2021, code sets will not include new patient level 1 code 99201. So we are going to see a deletion of code 99201 in 2021. New patient codes 99202 to 99205 will no longer require the 3 key components or reference of typical face-to-face time. Instead, each service includes a medically appropriate history and or examination, and code selection will be done either on basis of medical decision making or the total time spent on that date. So let's compare the code description for 99203 for 2020 with 99203 for 2021 so that we get a clear idea that what will differ. So in 2020, we required three key components for 99203, that is a detailed history, a detailed examination, and medical decision making of low complexity. It is completely changed for year 2021, and for a new patient visit we require only a medically appropriate history and or examination and a medical decision making of low complexity. So let's look into what are the 2021 requirements for ENM codes for 99202 and 99205. So the requirement remains quite similar to 2020 for medical decision making, that for coding a level 2 visit, we need a straightforward medical decision making. Level 3 requires low medical decision making. Level 4 requires moderate medical decision making. And level 5 requires a high medical decision making. The best thing which has changed is now for coding a level 3, level 4, or level 5, we do not require a specific requirement of detailed or comprehensive history and physical examination. A medically appropriate history and examination is required for all the code levels, which can be pertinent to the patient current complaint. The other way how we can code for this code is quite similar to 2020. That is, it can be coded on basis of the total time spent in the patient care. So as we can see, the highest time we can see is between 60 to 74 minutes, which is for CPT 99205. So one new thing which we are going to see in 2021 is a prolonged service code. So if the service is longer than 74 minutes, then AMA plans to create a new prolonged service code, which is temporarily referred to as 99XXS. So this is a code which will be used if the service is longer than 74 minutes. So there are a few rules of how we will be coding for the prolonged service add-on code. So the first rule is the prolonged service code will apply only if you choose the primary code based on the time. So if we are coding the primary ENM code on basis of medical decision making, then we cannot code for prolonged service code. Only if we are coding the service on basis of the total time spent in patient care and the visit exceeds 74 minutes, then we can add additional add-on code for prolonged service code. Second one, the new code will include total time with and without direct patient contact on the date of service. Remember that 99202 and 99215 also will use total time rather than intra-service time starting in 2021. So in 2020, if we'll see the code description, it clearly says that it counts only the face-to-face time spent with the patient. But that changes for year 2021. And now it will not only count the intra-service, but will also count the total time spent in the patient care. For example, before meeting the patient, if you have reviewed the patient medical records, even that that time will be considered under the time consideration. So we'll see that in more detail in the next slides, so that we get an idea that what all time activities can be counted. Third point is you will use prolonged service once for every 15 minutes beyond the primary service time. So if your primary service time is 15 minutes beyond the 74 minutes, we'll use it once for each 15 minutes beyond the primary service time. Fourth point is very important. The appropriate primary code will only be 99205 and 99215, which represents the longest time among the new and the established patient codes. So the prolonged service codes cannot be used for the lower visit codes. It can only be attached. So the primary codes will only be 99205 and 99215. So let's look into the established patient ENM codes. Uh, in 2021, level 1 established patient ENM code 99211 will still be available, unlike 99201, because that's getting deleted in 2021. But the code descriptor will not include the time reference. So in 2020, we had a time limitation of typically 5 minutes are spent performing and supervising this service, which is deleted for 2021. The code is still there, but there is no reference of time in 2021 for CPT 99211. So let's quickly compare a new patient code with an established patient code for year 2021, because both the codes in year 2021 will look alike, and the only difference will be one will be referring as new patient, the other one will be referring as established patient. Both the codes will require medically appropriate history and or examination, uh, and the level of medical decision making. So earlier in 2020, description of new patient code was very much different from the description of established patient codes. But now the code description for new patient and established patient will be very similar, except for one referring as new patient and the other one referring as established patient. So let's also look into requirement for 2021 requirements for ENM codes for 99212 to 99215. Uh, Similar as the new patient codes for 2021, the key component for deciding the level will be medical decision making or the total time spent with the patient. History and physical examination are no longer the key component in selection of the right code. Only a medically appropriate history or examination is required to be documented. So we will be selecting the ENM service code based on the following. One is medical decision making. Second is the total time for ENM service performed on the date of service of the encounter. Uh, this is a major change which we'll be seeing, that there is a increase in work RVUs for the outpatient ENM codes. So we can see that with the current work RVUs versus the 2021 proposed work RVUs, there is a great increase for some of the ENM codes, which we'll be seeing in year 2021. Okay, so let's revise that, what we have learned. So we know that CPT 99201 will be deleted in 2021. We know history and exam are no longer a part of the equation. We know that the level may be based on the total time or the medical decision making. So let's look into the time documentation bit more detail. So time documentation includes both the face-to-face and non-face-to-face time spent personally by the physician or other qualified healthcare professional on the date of the encounter. Time documentation will not include the time in activities normally performed by the clinical staff. So let's see time activities that counts. The activities that counts are preparing to see the patient. That means reviewing the test results, obtaining and or reviewing separately obtained history, performing a medically appropriate examination and or evaluation, counseling or educating the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information in the electronic or other health records, independently interpreting results and communicating results to the patient, family, or the caregiver, and care coordination. So these are the activities which we can count while calculating the total time spent in the patient care for that particular encounter. So if we are not going to code on basis of time, then the level of service will be based on the documented medical decision making. So let's see what is medical decision making. Medical decision making includes establishing the diagnosis, assessing the status of the condition, and or selecting a management option. There are altogether 4 types of medical decision making. It's either straightforward, low, moderate, or high. The concept of the level of medical decision making does not apply to code 99211. There are 3 main components of medical decision making. So the first one is problem point. That is the number and complexity of the problems that are addressed during the encounter. The second one is data point, the amount and or complexity of the data to be reviewed and analyzed. And the third one is risk, the risk of complications, morbidities, and or mortality of patient management decision made at the visit associated with patient's problem, the diagnostic procedures, and the treatments. So the 3 elements will define medical decision making of office outpatient visit in 2021. Uh, these 3 components are similar but are not identical to 2020 elements, because we know that in 2020 also we were considering the same 3 components, but it is not exactly similar to how it used to be in 2020. So let's review the E&M guidelines for medical decision making for 2021 and how it was in 2020. So problem points for 2021 states the number and complexity of the problems or the problems the provider addresses during the E&M encounter. Whereas in 2020, the guidelines instead refer to number of possible diagnoses and or the number of management options. For data point in 2021, the amount and the complexity of the data to be reviewed and analyzed. And it is now in 2021 further categorized into 3 categories. The first one is test, documents, orders, or independent historian. Second one is independent interpretation of the test result. Third one is discussion of the management or test interpretation with an external provider or appropriate source. So in 2020, medical decision-making guidelines also included the amount and the complexity of the medical records, test and other information involved. But in 2021, for data point, the guidelines expand the section significantly. So in 2020, we only had the test, documents, orders that needs to be documented in the medical record, which is significantly expanded. And now we also need to document assessment by the independent historians, independent test interpretations, and discussion of the management option with the external providers. Risk in 2021 includes the guideline says that it makes it clear that the options considered but not selected are still a factor in this element. and specifically after a shared medical decision making with the patient, family, or both. The 2020 medical decision making guidelines includes a comparable wording, but do not include the reference of the shared medical decision making. So in 2021, medical decision table will have three main columns, and the final column will be divided into three additional columns. So the first column will be the CPT code. The second column will be the level of medical decision, which will be similar as 2020, that is on basis of 2 out of the 3 elements of medical decision making. And the third column in the table of medical decision making will be elements of medical decision making, which includes the number and complexity of the problem address, which is also called as problem point. Second one, amount and or complexity of the data to be reviewed and analyzed, which is also called as data point. And risk or complications and or morbidity or mortality of patient management, which is considered as the table of risk, which by which we analyze the risk to the patient. So let's look into the level of medical decision making table so that we understand that what exactly is changing for year 2021. Uh, for code 99211 and 99202, that is straightforward medical decision making, there is no change. And for data, we require either minimal data or none of the data to be documented to code a straightforward for a straightforward medical decision making to code a level 2 visit. For level 3 visit, everything remains the same. Like medical decision making needs to be of low complexity, the problem point remains the same, the risk remains the same, and we see the major changes happening for the amount and the complexity of the data to be reviewed and analyzed, and that needs to be documented. In 2020, we were on only documenting the test and the documents. Uh, Test and the documents. That means what test has been, what test results have been reviewed, what test has been ordered by the physician. So we were only documenting the category 1, and now for level 3 we have 2 categories. One says the test and the documents, and the second category says assessment requiring an independent historian. So this is a new component added for level 3, which is assessment requiring an independent historian. So what is an independent historian? Independent historian is an individual who can be a parent, a guardian, surrogate, spouse, or a witness, who provides a history in addition to the history provided by the patient, who is unable to provide the complete or a reliable history. So for level 3, we must meet requirement of one of the 2 categories. So either it should have the test and documents to be documented in the medical record, or we need to have documentation of assessment requiring an independent historian. So this is a new term introduced for 2021. For level 4 visit, the MDM level remains the same, which is moderate. Uh, the problem point remains the same, and the risk, how we were reaching the risk, that is on basis of prescription drug management, or if there is an elective major surgery performed without an identified patient risk, or a minor surgery with identified patient risk. So the risk, number of problem points, and the level remains the same. The major difference for level 4 is again in documenting the amount and complexity of the data to be reviewed and analyzed. So for level 4, that is the moderate amount of documentation requirement. We can see 3 categories now. So the first category says test, documents, or independent historian. Second category, which is a new addition, says independent interpretation of the test results, which was performed by another physician or other qualified healthcare professional. And third category says discussion of the management or test interpretation with external physician. So to document the moderate amount of data for a level 4 visit, we must meet the requirement of at least one out of the 3 categories. So either we need to document category 1, which is test, documents, or independent historian, or category 2, that is independent interpretation of the test performed by another physician or healthcare or other qualified healthcare professional, or we need to document category 3, that is discussion of the management or test interpretation with an external physician or other qualified healthcare professional. For high complexity medical decision making, that is for level 99205 to 99215, we need documentation of extensive amount of data to be reviewed and analyzed. So what comes under extensive is we must meet the requirement of 2 out of the 3 categories. So the 3 categories are similar to the moderate complexity, but now for moderate we required to meet one to document one category out of the 3 categories, but for extensive we need to document at least 2 categories out of the 3 categories. So we need to document at least 2 of the 3 categories, either the test, documents, or independent historian, and independent interpretation of the test results, or we need to document the discussion of the management or test interpretation with an external physician or other qualified healthcare professional. So the major changes we have to make in how we are documenting our current data points. So far we were documenting what test results we have reviewed, what test we have ordered. So now we will be requiring 3 more things to be documented in the medical record, which is any assessment requiring an independent historian, or if we are interpreting a test result which is performed by another physician, or if we are discussing the management of patient or any test interpretation with the external physician or other qualified healthcare professional. So let's quickly look into the medical decision making example scoring, how we were scoring the medical decision making, and the total scoring to reach a level in 2020 versus how we will be scoring in 2021. So for example, if you're seeing a patient who is coming in for labs and monitoring of the hypothyroidism and obesity, and you do an expanded problem focused history on the patient, and a problem pertinent physical examination for the patient. So if the medical decision making qualifies for a moderate complexity, that you have done a prescription drug management, the patient is coming in for a complaint which is having a mild prognosis, and you decide to do a prescription drug management on the patient, and the overall medical decision making is of moderate complexity. In 2021 we required a detailed history and a detailed physical examination for an established patient, and a comprehensive history and a comprehensive physical examination for a new patient to code for a moderate visit, which is 99214. And if we were documenting less of the history and physical examination, as we can see for scoring using 2020, we can only code this as visit at a visit of 99213. But in as per the scoring for 2021, as physical examination and history is no more a criteria in deciding the level of the visit, and the level of the visit can be decided either on basis of medical decision making or on the basis of total time spent. So on scoring, on the basis of scoring of 2021, we can code this visit at a moderate visit, which is 99214. So this is a very good change which has come in place, because earlier, because of lack of documentation of history and lack of documentation of physical examination, even if the medical decision making was of moderate complexity, we were downcoding it to a level 3 visit. But now, as it is no longer, physical examination and history are no longer the key component, we can code the visit on basis of the medical decision making. So if the medical decision making is of moderate complexity, we can code it at a level 4. If it is of high complexity, we can code it for a level 5 visit. All right, so that's it from my side. Thank you so much. Any questions?
Hi, Neha. Let me take a look for you. One moment.
Sure, Jennifer.
Mhm. Okay, so let's see here. I have first question. Finally, before we get to our questions, we actually have a poll. So let me go ahead and launch that poll before we dive into our questions.
Sure.
I'm going to launch the poll. Please take a few moments to respond, everybody. Okay, wonderful. Thank you for participating with the poll. And we actually do have a few questions here, Neha, for you. So I'm going to give you the first question. The first question that I can see here is, if using time to select a code, should I document a time range or actual time?
You need to document the actual time and the activities you performed during the time spent with the patient, either in reviewing the medical records or discussing the management option with other physicians. So you need to document the actual time and the activities that you performed.
Wonderful. Thank you. Let's see here. Our second question is, if using time, do I need to list all the activities and the time spent doing each one?
You don't need to document the activities for time for each activity. If you document the total time and describe what activities were done, is enough. So for example, if you spent around 45 minutes caring for a patient, you can just write that I spent total 45 minutes caring for the patient, reviewing the labs, records from another facilities, seeing the patient, and documenting in the records.
Okay, wonderful. And our third question here is, which other E&M codes does these changes, or do these changes apply to apart from CPT 99201 through 99215?
That's an excellent question, because we are not going to see changes for any other code range. So these changes do not apply to other evaluation and management codes. It only applies to CPT 99201 to CPT 99215. So it does not apply to inpatient, observation, or any other codes like emergency CPT codes.
Okay, wonderful. Thank you very much, Neha. If we did not get to your question, we definitely have your contact information, and we'll be reaching out to you with responses to the questions that you have available. In addition, you can also reach out to us at marketing@hpiinc.com or visit us at www.hpiinc.com. Thank you very much for participating in the webinar today, and definitely reach out to us. Thank you very much.
Thank you, everyone.